This is what it
Well, she's going on Twitter. Actually, that's true. That's correct. Unless you want this one. No, thank you.
So because
Listen, I don't, well, I really looked at Twitter, actually very recently. I mean, I have had a Twitter account for longer. Yeah. Nice.
No.
Tell me when you think we should, I can start the introduction. Still think I'm interested, yeah, I guess I can do the introduction part and then we'll start. Dr. Rosen, can I ask you to sit down, please?
Yes, ma'am.
It's the only time I'll ever get him to listen to me. All right, I think we'll get started and hopefully some people will be drifting in from the break. I know the breaks are getting shorter and shorter because the sessions are so good. There's so much discussion. The break times kind of get eaten into a little bit. So I am here to introduce a very incredible person. This is for the Betty and Henry Pitt Quality Oration. It was established in honor of the HPPA past president, Dr. Henry Pitt, who's sitting here with his lovely, wonderful wife, Betty, who I've known for a long time, and really for his commitment to quality of care in HPB surgery. So today I am delighted to announce Patricia Turner is going to give this lecture. She's from the American College of Surgeons. She's the executive director and the CEO of the American College of Surgeons. She's a clinical associate professor at the University of Chicago in medicine. She was previously the director of the Division of Member Services at the American College of Surgeons. Before joining the college, Dr. Turner spent 8 years in academic practice in the University of Maryland. She was the surgery program director there, amongst many other roles. She's had several roles in national professional organizations or institutions, including a member of the board of directors of the Council of Medical Specialty Society, a corporate member of CEO of the Joint Commission, Special Society CEO of the Coalition member, and chair of the Society of the Black Academic Surgeons Foundation Fund. Past chair of the American College of Surgeons delegation to the AMA House of Delegates, and a past president of the Society of Black Academic Surgeons. She is an incredible person. She has a basic fellowship training in minimally invasive and laparoscopic surgery. It was completed at Mount Sinai. She did laparoscopic surgery, I think, at Cornell. She can correct me if I'm wrong up here, at Columbia University in New York. Her MBA was completed at the University of Maryland in the School of Business there. She's obviously board certified in surgery and a fellow of the American College of Surgeons. She's a member of numerous surgical societies, many of which she has led. I'm delighted to introduce Dr. Patricia Turner.
Good morning, everyone. Thank you for that kind introduction. And it's really my pleasure to be here with you this morning. And it's especially my pleasure to be here to present the Betty and Henry Pitt Oration. Really an honor to have been invited to give this lecture and the opportunity to talk about quality in the name of Dr. Pitt, who has done so much for so many as it relates to quality dating back decades, is really a profound honor for me. So I'll just say a couple of words about Dr. Pitt, again, who has been engaged with the National Surgical Quality Improvement Program since the very beginning. As I said, has been working on quality improvement efforts in all areas of surgery, in particular along the Surg-Onc service line, and in particular relevant to this audience in hepatobiliary and pancreatic surgery. But it's an honor to speak about quality to a room full of those who I know are committed to advancing it. So I have no disclosures. So a couple of slides about history, because I think it's relevant to inform the way that we talk about quality. So in the late 1800s and early 1900s, hospitals were crowded, they were dirty, surgeons were competing with one another, they were sometimes unethical in the way that they cared for patients, and there was variable training. You could theoretically have a lot of training and operate next to someone who had next to no training, and there was a minimal focus on outcomes other than essentially did the patient live or die. Those were really the only metrics that were of concern at that time. So if we move then to the early 1900s, Franklin Martin, known to some of you because he was one of the founders of the ACS, was really a formidable entrepreneur and organizer. And he understood that effective, high-quality medical education was essential for surgeons. And so he formed the Society of Clinical Surgery, and its job was to train surgeons better, to teach them how to operate, to allow them to learn from one another. And SGNO, this is the Journal of Surgery, Gynecology, and Obstetrics, published its first article in 1905, which really had to do with using iodine as a surgical antiseptic in OB care. So in 1910, Dr. Martin invited all of those who were subscribers to SGNO to come together in Chicago to learn about surgery. So for those of you who know the history of the college, that we were founded in 1913, yes, you are correct. The first clinical congress predated the founding of the American College of Surgeons. So he invited these individuals who subscribed to his journal, and he said, come to Chicago. And he expected 300 people, maybe 400, and 1,300 surgeons showed up in Chicago for 2 weeks of learning how to do surgery from one another. The program included lectures, it included OR demonstrations. They were able to go and watch individuals operate in some of the iconic Chicago hospitals at the time. And it was, by all accounts, a rousing success. So in 1913, the ACS was founded. And so one of the first things that the ACS did, and this was really based on the enthusiastic response to clinical congresses, which by then had been held in 10, 11, and 12 in Philadelphia, New York, and Chicago, the thought was that there should really be an organization. So it shouldn't just be from one year to the next coming together to spend a couple of weeks, but that there really should be an organization. And so in 1913, the American College of Surgeons was founded. And one of the first things that the ACS did was start to set standards for surgeons and for hospitals. And indeed, the American College of Surgeons' goals around surgical and hospital quality are the foundation of what we now know as a joint commission. In addition, as it relates to surgeons themselves, there were strict criteria in order to be a fellow of the college. Fellows were required to submit detailed operative notes. They had to submit at least 50 cases, and those had to be reviewed by a committee, and some 60% of individuals were rejected because the goal was to really have this be a high bar to join fellowship. And this was modeled after the Royal Colleges in Europe, where Dr. Martin had had previous experience. So another figure who may be known to some of you is Dr. Ernest Codman. So in 1918, the hospital standardization program was proposed by Dr. Codman, and it was based on this end result idea that he wrote about. And that was that staff should follow patients long enough to know whether their treatment was successful. Now, that seems incredibly obvious to us now, but at the time, that was extraordinary. And indeed, he was nearly run out of town on a rail because he suggested that some individuals who were really quite prominent at the time indeed had bad outcomes, and no one really wanted to hear that. No one wanted to objectively evaluate their cases because everyone was so sure that they were doing the right thing for their patients. And so this was one of the earliest quality improvement initiatives in surgery. The program was voluntary, but the results were eye-opening. So these are the results from that first set of evaluations. So in 1919, the first field results showed that 603 out of 692 hospitals failed to meet basic standards. And these were some of the most prominent institutions of the day. And the list was burned. Like, we do not know who was on the list that did well and who was on the list that did poorly, because the list was burned, and those memories are lost. But the important issue is that that really was the foundation of beginning to think about how we critically evaluate hospitals and how we critically evaluate surgeons. And the ACS Hospital Standardization Program, as I said, later became the Joint Commission, which was founded in 1951. So you can't really read it on the right, but that is actually a photograph of what is called the minimum standard, which is what hospitals were obligated to abide by. And so this was the notion of hospital standardization. And so organizing hospital medical staff, organizing the responsibilities, assigning responsibilities to individuals, and ensuring that only well-qualified and indeed licensed professionals were allowed to operate in your hospital was, again, a very creative and new expectation. Previously, you just had to know somebody and they would allow you to bring patients to their hospital, or you could pay to bring patients to the hospital. So the notion that you wouldn't be able to operate or have privileges unless you met a certain minimum criteria was a novel idea. And performing regular staff and clinical review, so looking at outcomes, maintaining thorough and organized medical records, which is to say you could look back and see how your patients did over time, or you could see if a patient had been operated on before. Those were all novel ideas. And then facilities that we think about now, X-ray labs, those sorts of things were not standardized at that time as well. So all of these were listed in the minimum standards expected of hospitals. So surgical quality programs. So as we think about the ACS and our quality programs that began soon thereafter, beginning in the 1920s and moving forward, the precursors of the Commission on Cancer and the Committee on Trauma were really established in 1922. Indeed, we celebrated the centennials of both of those programs last year. And you can see there on the left, an outline of the treatment of fractures, and you can see there on the right, the Commission on Cancer. And so they set standards for care as it related to cancer care and trauma care. The first cancer registry was founded prior to the COC, indeed, in 1920, and the first trauma registry in 1969. So throughout its 110-year history, the American College of Surgeons has been focused on advancing the quality agenda for surgeons, for hospitals, and for surgery patients. So fast forward, this is what our quality and verification programs look like today. So I don't expect you to be able to see all of those icons, but my point in sharing this with you is that we have a number of quality programs that have grown through our accreditation and our verification processes, that have grown from just looking at our data to making recommendations on how to improve care. We have registries, and I would just highlight for you that we are not finished. We continue to grow as it relates to surgical quality programs. So you can see the cancer programs there in red in the center, trauma programs in the center, and cancer programs on the right. But we have more than 24 programs that are focused on quality improvement. And it's really the hard work of Dr. Cliff Coe, who is the director of our Research and Optimal Patient Care Division, Samira Ali, and so many others, many of you in this room, who have contributed mightily to the work that goes on, and the incredible staff at the ACS that continue to highlight this work. So I'll highlight also that there are not only specialty-specific or operation-specific programs, but there are also programs that are agnostic to the case and really focus on the demographics of the individual. So there is the Children's Surgical Verification Program. There is a Geriatric Surgical Verification Program. There is Strong for Surgery, which is our prehab program. So these are agnostic to the specific operation or discipline, but still focus on the enhanced outcomes of surgical patients. So NSQIP, I hope everyone in the room knows about NSQIP, but just a moment or two on it. So first used in the VA as a result of public scrutiny that occurred in the 1980s. So people were incensed that our veterans were not getting what they considered appropriate care, and that outcomes for our veterans were poor in some cases and uneven across the board. And so in the 1980s, there was a public outcry that included Congress, such that law was passed that required that the VA report their annual surgical risk-adjusted outcomes in their 133 hospitals and compare them to national averages. The challenge, of course, is that there were no national averages. And so it was impossible to do this without some additional work. So patient factors clearly have an impact on outcome, as does the effectiveness of care that we provide. And then there's some element of random variation, and that equals our outcomes. So how do you figure out what the national standard should be? And so the work in the VA was to build a statistically reliable database that actually collected preoperative variables and risk factors and measured postoperative outcomes. And again, many of you have been engaged in this process since it was in the VA, but this required creating methods for accurate data assessment. The good thing about the VA is that you could do things by fiat in the VA. You could make a statement and it would be immediately implemented across all of the institutions. And the risk models were used to collect data on all 117,000 major operations, because again, we had all of the patient's data. There was, predating what we currently think of as the EHR, an opportunity for a veteran to be seen in any VA and for their records to be accessible. And so that allowed the ability to collect these data across the system and capture in a way that allowed us to create risk models. So it allowed for the first time comparable measurements of the quality of surgical care. So in 1999, after it was noted that you could actually impact outcomes and you could improve outcomes, the private sector wanted to get involved. So the private sector said, how is it that this is happening in the VA and we can't do it in the private sector for our patients as well? And so the pilot study with 18 private sector hospitals was started in 2001. And they wanted to demonstrate that the same sort of quality improvement effort could exist outside of the VA, where you couldn't necessarily do things by fiat, where there wasn't necessarily a single database, and where you actually could lose patients, because in the VA, again, to the extent that they all got their care in the VA, you could keep track of them and do their outcomes more easily. And this was done in collaboration with ARC and was wildly successful. So risk-adjusted 30-day outcomes were able to be calculated, and this was based on rigorous, clinically relevant data collected by clinicians. So the certified nurse reviewers, which is quite different than, and again, I'm talking to a crowd that knows this, but quite different than administrative or billing data, which is often what has been used and is not accurate in most cases, uneven in other cases. And when we train the trainers, we're able to enhance inter-rater reliability and make sure that we're getting not garbage in and garbage out, but strong clinically relevant data with very specific guidelines about what constitutes what finding. So the trained data collectors was an important element of it, on-site data audits, and then multiple surgical specialties were incorporated. And importantly, NSQIP also provided improvement tools. So it wasn't enough to capture the data, but in addition to capturing and just looking at it, we wanted to help improve the data. And so again, part of the work of NSQIP was to figure out what are the best practices, how do we share that back with institutions that want to participate. So you've all seen the caterpillar plots, but it's important to say that this is not something that was standard care prior to the NSQIP data. So you couldn't necessarily just pull up your hospital and see where you fell along the pathway. So on the left, obviously, are those individuals who are low outliers with an O to E ratio that is lower than anticipated. So they may have sicker patients, but their outcomes are better even for the sick patients that they have. And those on the right side are the high outliers, those individuals where the error bars don't cross the blue line there in the center, who have a higher than anticipated O to E ratio. So they are having more adverse events than would be anticipated based on the factors of the patient's pre-op variables and the operation that they had. So you can see there are some of the things that are measured in NSQIP. There's many, many more things, but the principle is that the items that we know are problematic for our patients were able to be studied in a rigorous fashion, and those data fed back so that there could be interventions at the hospital level. So there are now more than 700 sites, 20% of them are international. And the quality verification program, QVP, is really integrated into the very fabric. So an institution can participate in NSQIP and by that very action be involved in our quality verification program. There are millions of patient records. There's been more papers written on NSQIP data than any of us can count. And there are greater than 100 statistically risk-adjusted models. And the evidence-based tools are, again, where it's important. We want to help improve the improvement. So case studies, best practices are shared with those who participate in NSQIP programs. So I just put this here because over the years, NSQIP's been named the best in the nation, earned Innovation in Patient Safety Awards. So again, we continue to recognize the impact that NSQIP has had. I won't cite all of the papers, but I just put a few in here. So NSQIP helped in this particular study from Annals, 80% of hospitals improved complication rates, 2/3 reduced mortality rates. Participants were helped avoid complications, improve mortality, reduce costs, reduce morbidity and readmissions. And as we're talking about quality, those in this room, we are all surgeons, we all care about patient outcome and the primacy of patient outcomes. There are others who are perhaps more concerned about the financial impact. And so it's important that we have to demonstrate both, that we can bend the cost curve, not by ratcheting back on care, but by providing evidence-based care with fewer complications, because complications are incredibly expensive. So we can provide better quality care that is better for the patient and bend the cost curve at the same time. So interestingly, or importantly, hospitals continue to improve. So NSQIP and participation in quality improvement efforts, it's not a one and done phenomenon. So this is from another Annals paper. Hospitals continue to improve over up to 8 years, which is a time frame of this study. And so these interventions are sustainable. And indeed, the magnitude of quality improvement increased over the years that they participated in the program. So you saw continued improvement. So it is not something that happens once and then you're flat as an institution forevermore. So there are some additional registries that are, as you can see there on the screen, peds, thoracic, vascular, plastics, the surgeon-specific registry, which allows individual surgeons to measure their own data and benchmark it. The COVID-19 registry, which of course was established a couple of years ago, the NTDB, and the National Cancer Database. So some of our accreditation and verification systems, when you think about what we're doing at the ACS, you probably naturally think about cancer and trauma and perhaps bariatrics. I know that many of us know that the morbidity for bariatric cases has decreased by orders of magnitude over the years, but you may not think about the Children's Surgical Verification Program, or you may not necessarily think about the Geriatric Surgery Verification Program. Emergency General Surgery was established just last year in conjunction with the AAST. Vascular Surgery just established this year in conjunction with the SVS. And there will be, in addition to the inpatient modules that we're known for, we need to begin to move into the outpatient space. As we all know, many more operations are being done in the outpatient setting, and we have to move where the puck is going, if you will, and make sure that we also are able to assess surgical quality in the outpatient environment, which one might argue is even more uneven than in the hospital, because there are so many institutions that participate with varying degrees with all of the varying accreditation agencies that do outpatient care. And then on the horizon, high-risk GI verification and general thoracic surgery verification. So the Red Book, I think all of you have seen or have heard about before, and this really represents the minimum standards or optimal resources for surgical quality and safety. So patterned after the trauma optimal resources for care of the injured patient is the Red Book. So this is optimal resources for those who want to be involved in quality. There are 12 program standards. This forms the foundation of the QVP, and our first hospitals were QVP verified last year. So again, hospitals are putting their hand up and they're saying, we want to be verified as having the primacy of the surgical patient as a hallmark of what we do. Can you come in? And we want the ACS's good housekeeping seal of approval, if you will. So that is unfolding as we speak. And there are many more institutions that have put their hands up and said, we want to be in the next round of evaluation. So they also, interestingly, include a couple of international institutions. So one in Australia and two in Japan. So it's not just in the US or on the North American continent that individual hospitals are interested in engaging in our quality verification process. So a little bit about trauma. So again, trauma has been involved in our quality efforts since the very beginning. So 25% lower mortality, improved functional outcomes, more cost effective. So there are a number of papers that demonstrate that the ACS designation of level 1 trauma centers versus non-designated trauma centers are providing more effective care, more cost effective care, and the patients do better. Nationwide study of all 50 states, organized trauma care reduced mortality from MVCs by 8% for those who participated in our quality improvement efforts. And it's important to recognize that for many states, ACS verification is required in order to get paid for provision of trauma care. So it has become that inculcated in the very fabric of what we do in this country, that in some states, you literally cannot get paid for trauma care unless you're an ACS designated trauma center. So looking at cancer programs, we accredit some 2,100 programs. There's 1.5 million new cancer cases added and new cancer staging programs. And the synoptic operative reports, which I think are known to all of you, really are a step toward our ability to mine the data more effectively, making sure that we can get data out of the AHR in ways that help us to, in a more timely fashion, give reports back and talk about outcomes. Trying to, no matter how good we are at AI and no matter how good we are at natural language processing, it's much more difficult to get important data out of something that is in a narrative form than it is in a synoptic op report. So that is, again, the step toward making sure that we can give feedback data to you more quickly. Conducting national quality improvement projects and then providing, obviously, comprehensive cancer education. So quality measures drive best practice. We know that. I know you hear that every year from this podium, and we know that that continues to be true. This is just one example from the colorectal literature, an improvement from 62% to 88% adequate sampling of lymph nodes in colon cancer as a result of being engaged in quality improvement efforts. And then we are publishing the operative standards for cancer surgery manuals. And these are used by many of our individuals. And you can see there on the screen what the volumes include. And this is part and parcel of making sure that we're providing adequate support for those who want to provide evidence-based care. And then 10 cancer surgery standards are available, and you can see them here on the screen. I won't read them to you, but we have some that are already available, some that are in production and should be unveiled soon, and then some that are on the horizon. And again, as we think about more and more cases that it would be appropriate to gather cancer standards and highlight cancer quality, we want to engage stakeholders. So this is just an example of the synoptic operative report and how it is that, unlike some parts of the EHR where there's just a repetition of data and you get an error in there that's perpetuated throughout the EHR, we're trying to make sure that we're getting the accurate information that we know that we need, that is the factor that's going to portend better outcomes at the end of the day, and making sure that those are the data that are captured and that that's able to be mined from the EHR using AI and other techniques. So again, the more we can make the operative reports meaningful, the better off we are. And these templates are collected, transmitted, stored, and retrieved, and can be shared between EHRs. And that's another meaningful factor for our patients who do not necessarily always get their care at a single institution. So to be able to share this and perhaps even to link it to radiographic studies, to link it to previous chemotherapy regimens or to previous radiation therapy treatments, all of that is then able to move from institution to institution or across EHRs in a way that is agnostic is really best practice for patients. So there are a couple of additional specialty society collaboratives that are ongoing. So again, I won't read them to you, but working with our thoracic surgery colleagues, we've already talked about vascular plastic surgery. So knowing that working with the subject matter experts and the stakeholders across the entire spectrum of surgery is a priority for us. We are, after all, the house of surgery for all surgeons, and we want to make sure that we're capturing all of the elements that impact the outcome of surgical patients. So a little bit about improving the improvement, because again, it's one thing to have good data. And I think we've talked a lot about making sure that we capture appropriate data and that we share appropriate data, but it's not enough to simply look at those data. What are we doing to actually improve the improvement process? The data are essential, but they are not sufficient for achieving high quality. So improvement efforts have to be conducted well, and then we need to work again with collaboratives and with those in the local environment to make sure that we're having an impact more broadly, because we want to share best practices. And you can see there on the slide, these are some of the observations on improving efforts in surgical quality improvement. So I took these observations from Cliff Co because I think they're so meaningful. Observation 1, better hospitals knew how they were doing. They looked at their data. They evaluated their data. They didn't just capture it and let it sit. They actually had individuals who put their minds together, looked at their outcomes, so they could often catch the trend before it was a problem. They would see the trend towards something being problematic and they would intervene quickly. They would notice that they were doing well in some metric and would say, how is it that we're doing better than we did before? Let's assess what we did and let's do more of that. So importantly, observation 1, better hospitals knew how they were doing. Observation 2 from Cliff, better hospitals sought to incorporate standard evidence-based practice. So it was not enough to say, I think this is what we should do. They looked at what the evidence suggested and they hewed closely to that. And we all can think of situations in which perhaps the medicine literature differs from the surgical literature, or someone's got a way that they're used to doing things that isn't really borne out in the literature, but they do it that way anyway because they're a senior surgeon or what have you. So this is a discipline that requires us to use the evidence base to guide our conversations. And it also requires, importantly, that surgeons are in those performance improvement meetings, that surgeons are leading the conversation that is often multidisciplinary. We cannot intervene on the operative side and not talk about what anesthesia is doing. We can't intervene on the operative side and not talk about what nursing care is doing on the floor or in the PACU, or what our pharmacists are doing, or what our consultants are doing. So quality improvement is by its very nature a multidisciplinary effort, which is why we need more surgeons leading the charge and having leadership roles in our hospitals to change the conversation. And then finally, continual purposeful innovation. So if you think about the innovation cycle, I'm sure we've all read innovation books or business literature that talks about how you have the innovative step, and then it takes some time for that to become part and parcel of what you do. And for a while, you're on a positive trajectory. And then if you don't do something, you're going to fall off the cliff and you'll begin to descend. So what has to happen is there's an overlap between that positive trajectory and new innovation. And that has to be an ongoing cycle that happens in our institutions. We can't rest on our laurels because we will lose ground ultimately. So there has to be an ongoing, continuous cycle of purposeful innovation. So again, doing more of what we know worked well for us and trying to identify where things are going to go poorly if we don't intervene quickly. So the ACS is committed to improving the improvement process and helping you do that. And here are a couple of things that we're doing. So one is the Quality and Safety Conference, hopefully again known to all of you. Take a picture of that slide. It'll be in Minneapolis this summer, and we hope to see you there. It bears repeating that we are here to help with all of your surgical quality improvement needs, and the Quality and Safety Conference is a great meeting to bring your entire surgical team. That's the meeting to bring someone from the C-suite who may not yet be convinced of the importance of this effort. This is the place to bring your nurse reviewers. This is the place to bring members of your healthcare team, because it's not an entirely surgeon-focused meeting. And so please do join us for the Quality and Safety Conference. You can see there also the cancer meeting, which just happened last week in Atlanta. TQIP, our annual meeting around trauma quality improvement, happened in December. So these are meetings that are relevant and that bring together all of those who are part of the process of quality improvement. And it's important to think about the fact that if we, again, don't have all of the stakeholders at the table, we can make an intervention, think that it's unsuccessful, when really what was surrounding that intervention is what was unsuccessful. So improving the improvement, an online primer. So for those who are new to this work, those who may be trainees in the room, I know there are lots of young people or early career people here at this meeting, and you are to be congratulated on that. There is a primer that is for those who are really just starting this process. I'll say parenthetically, all of us are going to be required to make quality improvement more a piece of our career. The ACGME has in part of their core program requirements, quality improvement efforts for residents. So again, there will have to be documentation that residents are engaged in quality improvement efforts. And certainly we are building some modules that would be appropriate for that. The ABMS has decided that all boards need to be involved in quality improvement efforts as it relates to the way that they evaluate their diplomates. So I've been in conversations with the American Board of Surgery and other of the surgical boards because we can help with that. We can help build modules that will allow us as diplomates to stay out of trouble with our boards and will allow the boards to not have to reinvent from scratch quality improvement efforts, because this is what we do. And the boards want to stay out of trouble with the ABMS and the diplomates want to stay out of trouble with the board. And so our goal is to make sure that this becomes part and parcel of literally every surgeon's day-to-day job. So what's on the horizon? What are some things that I am thinking about as I look forward and think about what we need to be doing as an organization? So we need to coordinate all of our ACS quality programs into a more tightly organized construct to make it frictionless for the hospitals. I know many of you are leading in the conversations with your quality improvement team at your institutions. You may be having tough conversations with your C-suite because resources are finite. And when time comes to cut things, this may be on the chopping block, if you will. So we have to make it easier for institutions to engage with us. We have to make a frictionless environment. We have to make it easier for our surgeons to move from one platform to the next. And so we should be able to provide a similar experience for those of you who want to engage with us. Because again, based on your practice, you may be involved in multiple of our quality improvement programs, and it should feel the same and the user experience should be the same. Marketing both vertically and horizontally. When I think about the systems that are unfolding across the country, we really need to think about engaging with a system on quality improvement. So not just a quaternary care, highly academic and highly resourced institution, but what about the downstream hospitals that may have fewer resources or may not be so highly engaged in academic pursuits, or may indeed be small, and still those patients who receive care at those institutions deserve best quality care as well. Most patients in this country are not cared for at quaternary care academic institutions. Most patients get their care in the community. So we cannot ignore those institutions and what they need and how difficult it may be for them to implement some of our very involved processes. Incorporating social determinants of health into the data that we collect. It is impossible to ignore the impact of social determinants of health on patient outcome. And that has not historically been part of the factors that we capture, but we have ongoing conversations to make sure that we are capturing, again, the entire universe of what impacts our patients' outcomes. And then learning how to use AI to reduce the burden. How is it that we can, as I've said before, gather these data in a way that is agnostic to EHR, and perhaps some portion of what we need in terms of data collection can be done in that fashion, minimizing the expense, minimizing the requirement for a human being to capture those data, and importantly, not doing it in such a retroactive fashion. So right now, it takes us time. We're looking backwards. We're providing you data about what happened 6 months ago. We need to be able to give you real time or near real time, I'm being ambitious when I say that, feedback about your data so that you can make decisions in a timely fashion. So all of that will be aided if we're able to use AI to pull down some of those data. So what else is on the horizon? Well, there's a lot of people playing in the healthcare space that didn't used to be there. And I think we ignore this at our peril. So I'm sure all of you saw Amazon's $4 billion One Medical Play reveals about its healthcare ambition. So that deal has gone through. It is closed. So Amazon now owns One Medical. So when we think about the Amazon experience, which now is used colloquially to mean something that is smooth and seamless and easy, if patient care is provided by someone who knows how to do things smoothly and easily and who has the market cornered, if you think about the way in which they interact with Google on big data, then we are ignoring that at our own peril. Because if we don't start doing more with our data and giving more feedback and assessing and indeed ranking in some ways, or providing some way for some sense of ranking to occur, then someone else is going to do it for us and we will not like it. And the individuals that are in this space don't really care about patient outcome. And so what we have to do as a profession is think about how it is that we stay on the bleeding edge of where big data are going so that we can continue to do our own self-management, if you will, about outcomes. The government wants to know how to determine payment. We want to make high quality more resourced. And so again, the conversation that we're having with the C-suite is enhanced if what we can say to them is better quality gets us paid more. That's not what we care about perhaps as physicians, but that is certainly what our hospital system CEOs care for. And these are individuals that may never have cared for a patient, but are very mindful of what it is that they're willing to do. And we can rely on our own altruism, but that may not be as convincing to everyone else. Another thing to point out is that CVS just spent $8 billion for Signify Health. So it's not just Amazon that's in this space. CVS is in this space. Google is in this space. So if we think about the fact that the three largest providers of healthcare cloud computing are Google, Amazon, and Microsoft, we recognize that we have to be able to work in these spaces, or else someone else is definitely going to do it for us. So as I close, the surgical quality mark in our campaign. So the last thing that I want to highlight that's on the horizon really has to do with our quality campaign. One of my goals is to make sure that everyone knows more about quality improvement and that everyone at every institution is recognizing the fact that when we think about this motto that's been 110 years of history, to heal all with skill and trust, it's easy to understand the healing all. That really represents all patients, all surgeons, private practice and academic, rural and urban, all specialties, all patients. The skill part is also pretty straightforward. That is education, that is innovation, that is making sure that we are well trained, that is making sure that we know how to do the right operations. The trust piece is where quality shines. We have to be able to reassure our patients, the public, the press, politicians, that we are doing the right operation at the right time and that we're doing it in a way that is respectful of resources. And so the trust component is directly aligned with our quality work. And so we are unveiling, I did a little bit of a soft launch at Clinical Congress. I talked about this being on the horizon, but this ACS surgical quality mark that will be part of the engagement that we'll have with every hospital that's involved with any of our quality programs. And so you can see how this could be used in a waiting room, on the walls of the hospital. We've got US News and World Report making pronouncements about who's doing what well, and we know that they really are not expert at that, where we can provide that. And so the quality campaign objectives are really to drive awareness of and respect for the quality components that all of you are engaged in, to incorporate participation in payment metrics. Again, that is an important conversation that we have on the Hill. When I'm on Capitol Hill, talking about how we have to change the way that we value surgeons, that it cannot be fee for service forever. And we know that, but we should be paying surgeons for the value that they provide. We should be paying them for enhanced quality. And those are the conversations that we have to have on the Hill. So the primary stakeholders, the patients, the surgeons, the hospital systems, and indeed the payers themselves and the policymakers are all part of this campaign, which is named The Power of Quality. So you will hear more about that. If you haven't already heard about it, you've heard it here first or second, and you will hear more about it. And your hospitals will hear about the opportunity to engage with us in this way. So again, it's a multi-year effort. Again, I won't spend too much time on this because I'm mindful that it's quarter of. Multi-year effort and different audiences in every year. We're being very thorough in the way in which we roll this out, giving our surgeons the tools to have the conversations they need to have, because you are our best ambassadors. You are the ones who carry this message forward and explain to patients why this is important, and explain to those who don't care for patients why this is important. And you can be our voice on the Hill. You can be our voice when we talk to the policymakers and to the payers, how it is that, again, we can bend the cost curve in a thoughtful and deliberate way without cutting back on quality, and indeed by enhancing quality. So this is a video which I hope will play, and I hope you can hear. And this is right here at the end. Can we play the video, please? Thank you. So we are very excited to talk about the power of quality. We are very excited to highlight what this means to us, to our profession, to our patients. And we want this campaign to inspire, energize, engage, and establish what it is that we do and what all of you do. So I will leave you with this quote from the Greek philosopher Aristotle: "Quality is not an act. It is a habit, and it's a habit that is part and parcel of what we do every day as surgeons." So with that, thank you so much for the privilege of the podium.
Are there any questions? Dr. Jayaraja.
Dr. Turner, it's such a pleasure to have you here, and you are inspirational. Two questions for you. One is, the high-risk GI initiative is something that's very applicable to this audience, and I was wondering if you could comment on that. And the second question is, do you think that some of this quality designations should be linked to training? For example, in the ASMBS space, that has been linked, and I think that to try to improve how we deliver training, that would be an interesting initiative.
Thank you so much for that question. I'll start with your second question first. Certainly, we do value linking the training to payment in some cases, or to enhance quality, because we know that the training is associated with better outcomes. And so we would favor looking at what that might entail. As I don't think I need to tell this audience, working with the federal government and with payers can be a challenge. And so where CMS goes, often the private payers follow. But having them pick up any recommendations that we have requires a fair amount of work. We were just in a series of meetings where we have gotten the metrics related to the geriatric surgery verification program to be endorsed by the CMS, but that's not the same thing as actually paying more for it. So it's a multi-step process. So anyway, the short answer is yes, we do think that training should be part of the conversation. And I can't honestly say that I know exactly what that's going to look like. As it relates to emergency general surgery, high-risk GI, we are actively working on that effort. And so I would anticipate that that would be probably the next program to come online. But there are a lot of people that are putting their heads together and working with us to put together what are the modules that would be in that. So thank you for asking.
Dr. Royal.
Thank you, Dr. Turner. That was fantastic. With respect to the community practices and, programs that are evolving and developing, NISQUIP and the other quality programs are very resource intensive. And so they start low. And so I feel like I see a lot of these surgeons using SSR, and it hasn't traditionally linked to NISQUIP. Is there any goal or intention to try to link something so that community programs have a safe way of developing up to where they can eventually become a NISQUIP or more able to support quality programs?
Yeah, it's a great question. And it is a priority of mine that we figure out how to support hospitals with less resources to engage in the quality effort. I mean, it's easy, relatively speaking, although it's not even easy for the quaternary care well-off hospitals because we are all tightening our belts. But it's really a priority to make sure that we think about how to, engage NISQUIP Lite, or what are the components that are the key components, or how do we make it less expensive, like using AI, like we talked about before, but how are we able to make sure that there's some support for the smaller hospitals? The surgeon-specific registry is a little bit of a different beast, in part because one of the things that we are not enthusiastic about, because we don't think the data bears it out, is trying to make surgeon-specific rankings. And that's what some people want to do with individual surgeon data that's then tied back to the surgeon. And we're reluctant to do that for obvious reasons. I mean, there are a lot of factors that impact the outcome of the patient, and it's not reasonable and it's not borne out by the data to say this surgeon is better than that surgeon when we can't hold equal all of the other factors.
Dr. Feldman.
Right. Thank you, Dr. Turner. It was a great talk. Just a brief question. I was just curious how the college is thinking about, if at all, in terms of quality, incorporating patient-reported outcome measures in quality, especially for those procedures which may not have a high risk of complications. So just a brief thought about that.
Absolutely. I'm glad you asked that question. So the answer is absolutely yes. We are thinking about starting that actually with our geriatric surgery verification program, because those are situations in which when we think about what the patient wants from the outcome, that may be different than what the surgeon sees as success, and making sure that we incorporate that. And it will actually, our goal would be to roll that out for nearly every operation, because the same way that social determinants of health is something that needs to be incorporated on the front side, patient-reported outcomes need to be incorporated on the backside to make sure that we're actually teaching to the test, if you will, which is what the patients want, in addition to what we want as surgeons. So thank you. Yes.
Great. Well, thank you so much. That was outstanding and a great discussion. We look forward to see what's coming in the future. Yeah. And we have this gorgeous plaque.
Yes.
Yeah, take your stuff there. Awesome. Yeah, thank you.